And you think back to your own adolescence and how hard it was. Now add to that if you were going through adolescence with obesity. And then on top of that, put together what it would feel like if you started adolescence with obesity, but then didn't have it anymore. And all of that negative energy that was coming your way wasn't there anymore.
Should GLP-1 medications be used in children and teenagers with obesity? As these drugs become more accessible, it's a question that's going to bring up a lot of strong opinions and a lot of emotions. In this episode, we're joined by Dr. Evan Nadler, a pediatric obesity specialist who's performed more pediatric bariatric surgeries than anyone else in the United States. He brings both data and real-world experience to help unpack this super complex topic. And if you're planning on becoming a parent or know someone who might be, make sure to stay till the end because he's going to share an important message for prospective parents who are thinking about the future. And as always, if this show has helped you or someone you love, you can help us out by leaving a quick review on Apple Podcasts or Spotify. It truly means a lot to help our community grow. So let's get on with the show. I want to welcome Dr. Nadler. He is a pediatric obesity specialist, and he has written books about pediatric obesity and done pediatric obesity surgeries, and now he's talking about GLP-1s for the pediatric population. So thank you so much, Dr. Nadler. I appreciate you being here. Can you tell everybody a little bit more about you?
Sure. Well, first of all, thank you for having me. Second of all, call me Evan. If you have to call me Dr. Evan, you can, but Evan is fine. Third of all, my book hasn't come out yet. So I've written textbook chapters and multiple academic publications, but I am currently working on a book for the general public, not for academic people or even people in the medical profession necessarily, because I think it's so important to break down a lot of the stereotypes and a lot of the myths about childhood obesity. So my goal is really just to get the information out there to people, including that GLP-1, well, at least one GLP-1 medication is approved for children to use down to age 12. And there's actually data from another GLP-1 that's shown that it's safe down to age 6. And, I guess I have to pitch my pediatric telemedicine weight management practice that we just opened up, which we hope, if people need the access, which I'm convinced they do, because there isn't enough access to pediatric weight management out there currently, that we will expand to all 50 states, although we're only in about a dozen or so now, but hopefully more on the way. I'm a pediatric surgeon by training. I started doing bariatric surgery for children 20 years ago, more than 20 years ago now. Had the busiest pediatric bariatric surgery program in the country for a decade or more, and gave it all up 2 years ago to do all this other stuff. So I just I'll ask the question before you ask it, which is why I gave up such a huge, busy surgical practice. And the answer is, I was doing about 125 operations a year, let's say, and maybe treating another, let's say 75 just to make the numbers even. So 200 patients a year, but maybe there are 15 million children with obesity in this country. So at the pace of 200 a year, I was never going to make the impact that I had hoped to make, and got sick of banging my head against the academic wall. So decided I would take the fight right to the people, educate the masses. And so here we are.
Awesome. So GLP-1 being approved for children down to 12, and you said possibly 6. So as a mother, it would be concerning to me to put a child on something at 12 that they might need forever. So where are you with that?
Yeah, so it's a great question. The likelihood of the medication that's approved to age 12 is semaglutide. Its precursor, liraglutide, is the one that's been used down to age 6 in clinical trials and shown to have safety. But that medication has now gone generic. So the impetus for getting the approval down to age 6 probably isn't there, but it has been shown to be safe down to that age group. So the question you asked was sort of, why would someone start a GLP-1 in a child? Or who is that child? Is maybe another way to say it. And so as a patient advocate, which I am sort of first and foremost, especially patients with obesity, people with obesity. If your child, it's actually relatively simple. If your child has, and it's really the same for adults, and there really isn't a good reason for it to be different. If your child is suffering from either physical or mental negative effects of their weight or of their obesity, then it makes sense to be evaluated by a pediatric weight management specialist and perhaps get started on a GLP-1. There are other medications that are also used. And obviously I did surgery on lots of kids, but I mean, I can tell you that, the easy ones are kids with genetic defects that cause obesity. But I've seen kids who are like 8 or 9 who don't have a known genetic defect who have type 2 diabetes. And so to me, like I always sort of flip the question. I like to flip the ethical question when people get in my grill about ethics of starting children on medications or doing surgery on children. I flip it back and I say, well, is it ethical to withhold a known treatment that works just because of a patient's age? And when you flip the script, they're like, well, you know what, they're not developed, this or that. I'm like, I'm not, this is a yes or no question. It's like I'm in court. I'm like, just, is that ethical? And the answer is no, right? We have these tools at our disposal that we know work. We actually know that they're safe. The American Academy of Pediatrics has actually recommended anti-obesity medications down to age 12 for children with severe obesity. And so we know they are safe. We know they're efficacious. So why wouldn't we use them if the families were on board and if the patients were on board? Which obviously is where, the whole shared decision-making discussion comes up. In DC, when I used to have my surgical practice and also was very involved in the medical practice, or pediatric medical practice there, everybody who came in the door got on the very first visit, got a brief introduction to lifestyle, IHBLTs, which are sort of a pediatric thing, intensive healthy behavior, lifestyle treatment programs, EDS, and surgery, because we wanted to normalize it. It's just like, these are the options. Many people use multiple of these options, if not all of these options. Everybody gets lifestyle, but for, a kid who's, teenager with sleep apnea, fatty liver disease, metabolic dysfunction associated steatotic liver disease. These are weight loss is the best treatment. And whether you get that weight loss through medication or surgery or both, to me, I like to say I'm intervention agnostic. I don't really care how you get your treatment or what treatment you want. I just want you to get your health back in order.
So what are some of the concerns around a child's growth and development when they receive either bariatric surgery or GLP-1? I have a pediatrician who lives here in my neighborhood. She said she really wouldn't feel comfortable prescribing it before puberty. Like that was just her clinical opinion. And she is not an obesity specialist. Right. So I want to ask you.
Yeah. And I, again, would flip this. This is my thing. I like to flip the script. I'd ask her, do you think it's healthier to go through puberty with obesity? Or do you think it's healthier to go through puberty with a normal weight that's been achieved, or maybe not normal weight, but a lower weight that's been achieved through a medication? So, but I mean, the reality is that most of the kids we treat are past puberty, right? Because of, well, first of all, the age of first menstrual cycle is getting younger and younger in girls. And as people who are listening here probably know, adipose tissue makes estrogen and drives early puberty anyway. So the vast majority of our kids are well on their way to puberty by the time they get to us. But I've actually done more bariatric surgery on preteens, so 12 and under, than anyone in the country, and published it in case people think I'm just talking smack, which I'm from New Jersey, so occasionally I'll talk smack, but generally it's backed up. But the reality is, and this was actually shown in a manuscript by a group called Teen Labs, which was this big consortium that did a bunch of bariatric surgery in adolescence as part of an NIH study, the kids actually continue to grow. So they don't, as long as you support their nutrition, right, like which we do in everybody, it's not, vertical growth is still maintained, puberty is still maintained, people go through puberty normally, quote unquote, and I understand your pediatrician's concern because it's a legitimate concern, but the data just don't really support those concerns.
And so nutrition-wise, what are some of the things that the pediatric population may have to do differently if they're on this medication, or is it the same?
Yeah, so great question. And it's pretty much the same. I actually like to joke with or about the big manuscript that came out with, I think, the Lifestyle Medicine Group and the Obesity Society, maybe, or I can't remember, Obesity Medical Association, one of those two, and another, or maybe both of them. There was another group. And they came out with this great paper about how one should eat on a GLP-1 agonist. And I actually emailed the lead author because I know him. And I was like, did any of you guys think about talking to the surgeons about this? Because we've been treating people who don't eat after surgery for about 30 years now. We know exactly how people should eat on a GLP-1. And actually, it's interesting. It's actually not much different between kids and adults. It's still protein heavy. It is, it's basically protein, hydration, multivitamin. Like I would tell my patients that over and over and over again, the surgical patients. And with the GLP-1s, it's pretty much the same. When you don't have much of an appetite and you're only eating 3 to 5 bites a day, the protein is the one piece of the puzzle that's hard to get. I mean, you can do protein shakes, but protein's hard to get in any other form other than orally, or I guess through eating food. You can replace the vitamins. You can replace what fruits and vegetables give you in large part with a multivitamin, although they're not exactly the same. And then hydration is always the key. We would say 64 ounces of fluid. I think that's the same for me with a GLP-1. I think the GLP-1s, not only do they cause nausea, obviously, but they can cause constipation, just like surgery can cause constipation. So the best cure for constipation is movement and hydration. Mm-hmm. So, I really treat my GLP-1 patients' diet and everything actually very similar to the surgical patients because it's really not that different. GLP-1 weight loss is a little bit slower than surgery weight loss, but the mechanisms are similar and how you feel when you're on one is similar. Mm-hmm. So yeah, it's not as different as people really get very, what's the right word? Cautious when they're talking about kids. They don't want to, they're like, we don't want to do any of this stuff, because they want to be careful. It's like a child. But for those of us who are like deep in it and who have been in it for a long time, it's the opposite. We're like, the kids need the treatment more than the adults. And we need to get on this sooner, earlier, lower BMI, everything. And, it's an uphill battle, but it's a battle that we all fight because we're so passionate about sort of changing the narrative so that people can understand a little bit more about kids.
Sure. And so around the preteen age, there's an increased risk for eating disorders. So how are you managing that or screening for it or discussing it?
Yeah. So it's important. And everybody who, before they get started on GLP-1, gets a bunch of screeners for depression, for anxiety, for eating disorders, and so we do try to pay attention to that very carefully. But, the sort of ironic thing about that concern is that the data that are out there actually show that being involved in a weight management program, if you have obesity, lowers your risk of an eating disorder as opposed to increasing it. But I think what happens is that the psychologists or the providers who are in the eating disorder community, they sort of see the numerator. They see, oh my God, there have been 10 patients who have been referred who have eating disorders because they were taking GLP-1s. What they don't realize is that there are 1,000 patients who've taken GLP-1s who have not developed an eating disorder. So they're looking at, 0.1% or some really, or that would be 1%. But they're looking at a small number of patients. So there's actually a book called The New Food Fight, which is written by a friend and a colleague of mine that sort of discusses the eating disorder community and the obesity community and how they sort of would be better served working together as opposed to separately. And I think that's really, I think if I were designing the perfect program, there would be, an eating disorder specialist involved with the obesity treatment specialists because, just because of that concern. And frankly, I would argue that a disease where your food intake causes you medical problems is an eating disorder. Like the eating disorder community has its own definitions that are strict, but I think at a minimum it's disordered eating, but it's probably closer to an eating disorder. And frankly, GLP-1s help treat that eating disorder. And they're being investigated in binge eating disorder currently. So there might be more on the way about GLP-1s and what they can do for people with eating disorders.
I interviewed a woman who is in eating disorder recovery and on a GLP-1 for PCOS. And she said that her obsessive thoughts about food that she found with the eating disorder were
significantly decreased with the GLP-1.
Yep. And again, it's this food noise thing that people are talking about all the time.
Let's talk about one of the biggest misconceptions in this space, that GLP-1s are a magic pill. I know from experience and from countless people in this community, yes, these are medications that can help you lose weight. But without the right nutrition guidance, it's easy to lose energy, muscle, or gain the weight back if you have to get off the medication. Berry Street is helping change that. They connect you with registered dietitians who understand the GLP-1 experience, things like appetite loss, slower digestion, uncomfortable GI symptoms, and what it takes to keep your nutrition balanced when you're eating less. They'll help you build a way of eating that works with your body, not against it, to help you make progress that's not restrictive, but sustainable. The best part, Berry Street is covered by insurance, so you get $0 copay and a real expert helping you build a lifestyle for the new you. To learn more, visit berrystreet.co/hub to find your dietitian and start building habits that last. So let's say a child is able to be successful on the GLP-1. And so what is like the long-term prognosis? What is going on with that child at 50?
Yeah. Well, we don't know because the GLP-1s haven't been around long enough for us to know. But so, and one of the studies that I don't know that unless I haven't seen the study, but, in adults, the idea or the numbers that I know of are that about 80% of people who stop their GLP-1 regain their weight.
Mm-hmm.
And I think I just saw someone post on LinkedIn about the more weight you lose on the GLP-1, the more weight rebound you have when you stop it. I don't know that study's been replicated in adolescents, mostly because there are probably not as many adolescents who've had it, who've been on it so that you could do that study. And I don't know whether if you change your eating habits, we hope that if you change your eating habits as an adolescent, it's easier to maintain those eating habit changes throughout adulthood. But in childhood obesity, the genetic and the epigenetic drivers of the disease might be more stronger or more significant than in the adult worlds. So I don't know whether that's going to happen. But I think, I think the obesity field in general is moving away from sort of like meds or surgery and maybe more about how the two can work synergistically.
Mm-hmm.
And I think, maybe if you're on a GLP-1 at 15, maybe you still end up with bariatric surgery at 25. But maybe that's better for you that you didn't have surgery at 15. I don't think that's going to be the case. I think they're equally good at all ages. But I think there's just so much unknown out there that right now, I can say it's better to have your obesity treated than not treated. I can't say what 30-year follow-up will be. But I have, there's actually, again, surgical data. No, this is a GLP-1 broadcast, so people don't necessarily want to hear about surgery. Although everybody should know that GLP-1 levels change after surgery. And it's actually in large part how a lot of the GLP-1 research got started because people were measuring different hormones after surgery and trying to figure out how surgery worked. So don't hate on me for bringing up surgery all the time. They are related, I swear. My point is going to be there now 15-year surgical follow-up data that show that the health benefits of surgery during adolescence are present in most patients up to 15 years out, and even in patients who've regained some of their weight, which is a really interesting finding. So I think in general, it's going to be, I might not be around to see it, but I believe that when all the science sort of comes out, it'll sort of show that actually intervening in adolescence or younger intervention will be better for basically everybody.
Mm-hmm. And how compliant are your patients? Because I remember I'd occasionally see a type 1 diabetic in the hospital when I worked there who was like, forget this insulin thing, forget this thing. And then, what would happen.
Yeah, exactly. So I would say my patients are probably more compliant than adult patients. And you think back to your own adolescence and how hard it was. Now add to that if you were going through adolescence with obesity. And then on top of that, put together what it would feel like if you started adolescence with obesity, but then didn't have it anymore. And all of that negative energy that was coming your way wasn't there anymore. So most of my patients are definitely committed to the program because they are and this is more surgery than GLP-1s, but the same holds true for both. But they're the positive feedback of the weight loss is so important to them.
Mm-hmm.
And, so they're not generally, they're kids, right? So they're not perfect. And I actually, I used to go, basically every patient I take care of who's an adolescent, I figure they're going to break the rules at some point because that's what adolescent brains are programmed to do. And so I don't condone it. I try not to make huge, I try not to make it a catastrophe if they do. And then sort of just try to explain to them, listen, you're going to have wasted a lot of time and energy if you do that a lot. And, I'm pretty sure you don't want to go back to the way you were. So let's limit how many times you break the rules or something.
Sure.
Like that.
Sure.
But there are a lot of myths about childhood obesity and pediatric patients, among them that they're non-compliant. But, and I've actually had a lot of experience with neurodivergent patients who are another group that get sort of accused, for lack of a better word, of not being able to follow the directions. But the kids I've had kids who are better than their parents about following the rules. Mm-hmm. And the parents are also generally there to help, steer the ship if it starts to veer off course a little bit.
Sure. That's great. So you mentioned that you're also involved in the development of some new therapies for GLP-1. Can you talk just a little bit about that?
Well, what I was involved in with the GLP-1 development was actually using it in kids after surgery. I've published on that. And it's sort of interesting because the kids who didn't respond to surgery also were more likely not to respond to liraglutide because that's what we're using at the time. So it makes you think about the biology again, whether they just have a more severe form of the disease. I think the other indications will be younger and younger patients and whether or not, a 7 or 8-year-old who has obesity issues should get on generic liraglutide. I think it's going to become a discussion that people talk about. And I think the main thing what I'm really sort of investigating or trying to do is whether or not, pediatric telehealth. So weight management for kids centers around the country are few and far between and mostly located in urban academic tertiary care hospital type places. So what do folks who don't live near those places do? So we're piloting, our telemedicine program, and it's not just prescribing GLP-1s, but it's other, it's the whole lifestyle, other medications, the whole thing, not surgery, obviously, because we don't quite have a way of doing that remotely yet, but maybe someday.
Sure.
But that's sort of I would say, and I have a couple other sort of program development projects on the way, but that's sort of where I would say I spend most of my time in terms of investigations and trying to understand. I have published a ton on surgery in children with special healthcare needs and autism spectrum disorder. And I just haven't gotten there yet with GLP-1s. So that's another patient population that I'm really interested in because they have a higher incidence of obesity and require treatment. And, for years and years, they weren't really offered it because of whatever their differences were.
So what is your theory about why some people are non-responders? Like just severity, genetics, microbiome? I've heard a lot of theories on this podcast.
Yeah. Which is your favorite?
I like the microbiome because it seems like a mystery. Like there's these bugs controlling our stuff. I don't know.
Like aliens from outer space control. So I'm not a microbiome advocate. For me, it's epigenetics. Another mystery, by the way, epigenetics. Like people toss that word around without even knowing what it means. But for those of you out there, what epigenetics, the field of epigenetics is the field of how your DNA is modified by the environment. And whether that's food environment or microplastics or forever chemicals or pollution, all of them may play a role in changing how your DNA. Now, it doesn't change your DNA structure. For those of you out there who know anything about DNA, you have your C's, your G's, your A's, and your T's, and those stay the same. But what it does is it changes how your DNA turns into protein and how your DNA functions. And so I think that's why, well, first of all, I think that's how ultra processed foods exhibit their negative effects. Mm-hmm. Because I I usually talk a lot about the intergenerational transmission of obesity, and epigenetically modified genes can be from parent to child. And that the food people are always saying, well, genes can't change in 50 years. True. DNA can't change in, well, half true. DNA can't change in 50 years, but epigenetics can for sure change in 50 years. And so I just think that I think that kids is probably genetically driven and epigenetically driven, but also, there's lots of data about the importance of the in utero environment and maternal diabetes and maternal gestational diabetes, which is that's probably an epigenetic driver, but it's also hypothalamic imprinting, if you want to get into all that. Long answer to your question, but I think I'm in the epigenetics camp. The microbiome's interesting, and I've studied and published that, but in a group of my patients, their microbiome didn't really change a whole lot after they lost a lot of weight after bariatric surgery. So that sort of took the wind out of my microbiome sails, so to speak.
Sure. Yeah. Multiple factors that play a role. So if people want to get help with helping their child struggling with obesity, what is the name of your program, and where can they find out more about your work?
Sure. Thank you for asking that. So procaretelehealth.com is where you can find, I hope that's right, but I think that's right. I'll
get it in the show notes if it's not.
Thank you. So that's like the, it's our clinical practice. My website's easier to remember because it's Obesity Explained. And that's actually the name of my YouTube channel as well. I'm probably going to change those to Childhood Obesity Explained and Childhood Obesity Explained on YouTube. But the reason my book isn't out is I spent about a year working on a book that was really about all of obesity, and then sort of decided that I really should focus on the kids because that's where my wheelhouse is. So the website and the YouTube channel were more towards my first idea about the book. And now I think I probably change them at some point. I probably have to keep both domains so that people can still find me. But yeah, I shouldn't be that hard to find, to be honest.
Awesome.
And I'm happy to actually talk to, anybody who email me or whatever. I can just give my email address too, which is evan.nadler@epnmd.com, which are my initials, and then MD. Because really, again, I'm just here trying to help as many people as I can, and I'm happy to chat about this kind of thing with anybody at any time.
Awesome. Well, I really, really appreciate your insights. This is a topic I've been wanting to cover for a while because, I'm a mother and I care about the future of the kids. So I really, really appreciate you coming on today.
My pleasure. And I parting shot, I guess, maybe. But first of all, I'm happy to come back anytime because I could talk about this stuff forever. But I think what is really important that people may or may not think about is that their health before they conceive is a huge driver of their children's health. So even if no one on this podcast has a kid suffering from obesity now, if there's anybody out there thinking of having kids, it's really, and both mom and dad, it's not just one or the other, it's both. It's really important to get your own health metabolically optimized before you conceive to try to, minimize the risk of your child having metabolic issues themselves. So that'd be my 2 cents for the listeners here is, help yourself to help this generation to help the next generation.
Yeah, absolutely. I completely agree with that message. So thank you again, Evan, for being here. I appreciate your insight and your advice.
My pleasure. Thanks so much for having me.
Thank you so much for listening to this week's episode of the GLP-1 Hub podcast. This is a topic I've been really wanting to cover for a long time because it's very interesting and, like I said, can stir up a lot of emotions and feelings when it comes to kids. And I would love to connect with you more, so make sure that you are on our newsletter. Every week I send weight loss tips and other announcements about what's going on in our community. And so you can grab that in the show notes. And when you subscribe to the newsletter, you will also get a free 7-day meal plan created by me. And finally, make sure to check out our membership. We are working hard over there to make sure that it's going to support you in the best way possible this year on your GLP-1 journey. And I will see you in the next episode.